What I'm going to be covering today is mainly all the aspects of altered sense of smell and taste in COVID-19. And you probably know that this symptom was not listed as one of the symptoms of COVID-19 before April 27, 2020 by the CDC. The symptoms related to COVID-19, and those are screening symptoms actually, changed on 27th of April, where the CDC added 6 more symptoms. One of them was the new loss of taste or smell, and this loss is usually sudden loss, and it was described in different ways actually. This is the spectrum of the abnormalities that you would see with the altered sense of smell for those patients. Most patients would actually complain of absence of all smell function completely, and this is what we call anosmia. However, a certain percentage of patients would actually have hyposmia, which is the quantitative the reduction of the smell function. So the quantity of the function is decreased, and they're still able to smell something. However, it is much less than before. A smaller percentage of patients would have phantosmia, which is the perception of smell without odor present. And this is actually been described in many patients where they are smelling burnt toast, something that is not present. However, they smell that odor and they complain about it. And in good percentage of patients, what you would see that they are actually smelling smelling something. However, it is different smell, and this is what we call parosmia. It is altered smell perception with the odor present. And the worst that patients complain about is the cacosmia, which is perception of unpleasant smell with or without the odor present. They may smell something without being present, but it is bad odor, and they complain about it, and they say it stays in the nose and they cannot get rid of it, and it bothers them a lot, and it makes their life miserable. Patients may, most of the time, they may have altered taste in addition to the altered smell, and they are related to each other most of the time. But certain percentage of patients may have only altered taste without alteration of the smell. So there are consequences of altered sense of smell, and those are actually major ones. So number one, safety concerns, because you want to make sure that the person is safe in the environment that he's in and able to detect any unusual smell like gas leak or burn in the house. So if he's not able to detect that, we need to make sure that they have an alternative mechanism to be safe. Of course, it's a real problem for the mothers who are at home trying to cook and cannot taste or smell the cook that they have. Patients with this may have decreased appetite and not able to eat, and they may have weight loss as a result of this, because it is actually in good percentage of times it may last for weeks. It may be more than a few months too. It will have some social relationship effect and emotional problems, in addition to the personal hygiene, as the person is not able to smell anything that is related to his personal hygiene. So we need to understand that even though probably number one cause of altered smell during this pandemic is COVID-19, but the other causes are still there. We're still going to see altered sense of smell because of nasal and paranasal sinus disease, such as rhinosinusitis from any other viruses, nasal polyps, allergic rhinitis, or olfactory neuroblastoma. We're going to see the majority of cases from COVID-19. However, any upper respiratory tract infection can cause alteration in the smell or the taste. Of course, any post-traumatic facial or head injury, CNS disorders, Alzheimer's disease, Parkinson's, mainly dementia, and you can see the other conditions listed in this slide here. I'm going to share all those slides with you so you can actually keep a copy with you. Environmental and chemical exposure, such as the methyl acrylate vapors, cadmium dust, chromate. You can see here a list of other chemicals that can actually affect the sense of smell. And lastly here, some endocrine disorders such as hypothyroidism and diabetes mellitus may affect the sense of smell. And also, same thing for the taste. It has a differential diagnosis that you need to be aware of, multiple conditions from infections, inflammation, normal aging, nerve damage, vitamin mineral deficiencies such as B12 or zinc deficiencies, metabolic and endocrine disorders, neurologic disorders, environmental and chemical exposures, all can affect the taste sense. So what we're going to be doing now is we're going to be talking about the prevalence, the prediction, the etiology, duration, and recommendations. First, the prevalence. And this is actually a big meta-analysis that was published recently in the Gut and looked at 18 different studies that described the alteration of smell and taste in those patients. And the conclusion of the study that the prevalence of alteration of smell is around 45%. The taste alteration is 41%, and combining the two together is around 47%. And in the same study, they were able to detect that it is less prevalent in China and Taiwan compared to Middle East and Europe. The average age was between 28, it ranged from 28 to 66, depending on the studies. So it is more in the younger population than in the older population. And it was seen more in outpatient than in hospital settings. And it was also seen in more females than males in the same study. And there's a very nice study that is not yet published. It's available in Matrix IV, and it compared the prevalence of this symptom depending on the geographic area. So in East Asia, the prevalence was 13% with a good confidence interval. Compared to the Middle East, it was close to 40% in the Middle East. However, in Europe and America, it was actually much more than what's in Asia and even in the Middle East. In Europe, it was close to 57 to 60%, and in the Americas, whether we're talking about North or South America, the rate was close to 67% of patients would be complaining of altered sense of smell. Now, is this going to predict for us that those patients having COVID-19? So if you have a patient coming to your clinic and complaining of alteration of the sense of smell, what is the likelihood that this may be related to COVID-19? And this was answered in the same study that Leo has published in Gut and showed that it has a sensitivity of almost 55%. The specificity was relatively good, 82%. And that gives you a positive predictive value of 65%. Meaning if somebody comes to you with alteration in the sense of smell, and you would say without looking at anything else that this is COVID-19, that will give you 65% accuracy rate. But if you look at the other symptoms associated with it, you can increase the accuracy to 72%. So out of 10 patients, you can accurately diagnose 72 patients with COVID-19 without even doing the swab or the PCR. The negative predictive value of the symptom is better than the positive, and it reaches 74%. And this is actually translated into 6 times more to be associated with COVID-19. So the presence of taste or smell alteration is associated with COVID-19 in 6 more times compared to those patients who do not have the alteration in the sense of smell. Similarly, in another study that was published in the International Forum of Allergy and Rhinology, showed that those patients who have alteration of sense are likely to have an outpatient mild course. So they are seen more likely in the outpatient settings compared to in-hospital settings. So it is actually predicting that the disease will have a milder course compared to those patients who do not lose their sense of smell. In terms of the etiology, it is actually speculated that it is related to the infection of the nasal mucosa, specifically the cells that have the ACE2 receptors. And as you know, that better than me, of course, that the olfactory epithelium has 2 different types of cells. The first one is neuronal cells, which the olfactory sensory neurons and the immature neurons, and the other type of cells are the non-neuronal cells represented by the basal cell, the sustentacular cells, and the Bowman's gland. Now, in a very good study published in the Science Advances, it showed that the ACE2 receptors, which are the main receptors for the virus, are mainly present in the non-neuronal cells, and they are not present in the neuronal cells, which is actually very important, because that tells me that the disease is involving those cells, and those cells have the ability to regenerate. So it tells me that most likely the sense of smell will eventually come back. Now, we don't know that yet for sure. We need to wait for the results of the study, the other studies, and to confirm these findings. And the other receptors that is needed to get into the cell, it is actually present in both. But as I said, you really need the ACE2 receptors for the virus to attach to the cell and get inside the cell. So in terms of the taste, it is most likely related to the inhibition of the retronasal pathway, as we know that the smell is related to, or the taste is related to the smell. If you lose a sense of smell, most likely we're going to lose the smell of taste. But there's also speculation that it may have a direct effect on taste receptors, especially in those patients who do not lose the sense of smell. And let's not forget also that the virus may get entry into the CNS system through the olfactory system, and that's why we do have symptoms of encephalopathy in different manifestations. So the most pressing question is the duration of symptoms. Patients are actually asking you how long those symptoms would last. And in a good study that is published in the JAMA otolarynggeal head neck surgery, it looked at 202 patients. The patients who had altered sense of smell and taste were 113 out of those total patients. And after 4 weeks, that what they found in this study, that not only the patients continued to complain of dry cough and shortness of breath, but almost 51% of patients continue to have alteration in the sense of smell or taste. And after this 4 weeks, only 49% of patients said that all symptoms resolved. They're not complaining of any problem with this issue at all. However, 40% other patients reported that the sense has improved. However, it did not completely resolve yet. So we're talking about close to 90% of patients. They either had resolution of the symptoms or improvement in the symptoms. And almost 10% the alteration of the sense of smell was still present or even worse after 4 weeks of the disease. So what are the recommendations I'm going to come up with? In those recommendations, the management of this disease is actually in 4 different categories. The first category is reassurance. You need to reassure your patient that probably around 90% it's going to get better or resolve within 4 weeks. So it is very important that the patient should not actually panic. They should not say that, well, it's going to be lost forever or anything like this. No, it is 90% of the cases. Now we know that it's going to come back. And the other concern is we need to make our patients aware that there are some safety concerns related to the inability to smell anything that may be dangerous, such as gas, combustion, smoke, or chemicals around the house. And they need to make sure that they take extra caution about that. And if we get through this, we need to talk whether there's medical therapy and what we do with the olfactory training. And in order to do this, actually there was a very nice review article that was published in June 24 that looked at multiple studies available in the literature in regards of treatment of post-viral olfactory dysfunction. So we're talking about all the viruses, and of course most of those studies were prior to COVID-19, but I think it's the same thing is applied in terms of our recommendations at this point till we get more data in regards to this topic in the near future. And it's important to know how they classified their recommendations. It was based on the defined grades of evidence and from grade A to grade D. If it was well-designed randomized controlled trials, that would be grade A, and the bottom would be expert opinion, case reports, or the C, observational studies, and the B, randomized controlled trials, but not with some limitations. And those studies actually, the studies were classified into also 1, 2, 3, 4, 5 grading system, where one would include properly powered and conducted randomized controlled trials. It could be systematic review with meta-analysis. Grade 2 will be well-designed controlled trial without randomization, and grade 3 will be case-controlled studies, retrospective cohort studies, and 4 case series without intervention, cross-sectional studies, and 5 would be opinion. This is some definition of the abbreviations they used, and the test, most of the tests that used, and you are familiar with this more than myself actually, the TDI, which is threshold discrimination and identification score. Some of them used Toyota, Takagi, olfactometer to identify the level of alteration in the smell sense. Now we come up to specific recommendations, and what they looked at is 6 different topics. The first one was whether systemic steroids would make any difference in these patients. And you can see the opinion here, the recommendation level colored in this orange color. That means that it's optional. You can decide yourself about whether you want to give the patient systemic steroids or not. But this is coming from the fact that they looked at 1 level 3 study and 5 level 4 studies. You can see that the level of those studies is not high at all. We're talking about level 3 and 4. And they showed that some improved objective olfaction across multiple psychophysical tests. There's of course potential side effects of systemic steroids. The cost is minimal to those patients, so it was left for the physician's judgment They made it optional. If individual physicians can make that decision, I cannot fault you if you start your patient on systemic steroids. But I would actually be myself, I would be very careful before I start systemic steroids. And no matter what, you would not give systemic steroids to any patient within the first 1 to 2 weeks. I would say 2 weeks to make sure that you're not suppressing the inflammatory response of the body against the virus replication. So if you give it early, you may increase the replication of the virus. The British Society has made clear recommendations that it should not be given within the first 2 weeks. If you want to give systemic steroids, you have to wait till after the second week before you make this. If you want to give it specifically for the alteration of the sense of smell. Now, more commonly, probably topical steroids would have more role here than the systemic steroids. And this is actually evaluated based on one level 1 study and 3 level 4 studies. However, there was a problem with that level 1 study, that those patients were on systemic steroids before they were given the topical steroids. Anyhow, the harm is minimal. The side effects is local irritation, possible epistaxis, so minor inconvenience for the patient. I myself do not like put any inhalers in my nose, but others can tolerate it very easily, and it is not expensive. So it is a very good option. It may actually be the only option in terms of medications that we have to be given to those patients if they insist that they want something to hasten the recovery of those patients. But you need to know that, and you need to tell the patient that, well, we're not very confident that this is going to improve the symptoms. You may try it, and we may see how it looks. We will reevaluate and decide whether we need to stay on it or not. In terms of the intranasal sodium citrate, is also similar to the previous recommendations. It is optional, and it is based on level 1 study and level 2 1 study. We have level 3 1 study also. The cost is minimal, and the harm is also minimal. And based on the results of these initial studies, there is some benefit that is cited with those patients, and is an option available to you if you want to use it to your patients. However, for oral zinc sulfate, some patients were given zinc to improve the symptoms, and that is not supported with good outcome from these studies, and the recommendation of the article here is against. So we do not recommend to give zinc for the purpose of improving the sense of smell for those patients. There's a potential for harm if you extend the use of zinc. Of course, some people are treated with zinc for the COVID-19 infection itself, and aiming to improve the immune response of the body, and hoping that we can fight the virus in a better way. But that is also limited to 5 days. We do not extend giving zinc more than 5 days. Here, for the sense of smell, in the studies was more than 5 days, and there's potential for toxicity. So they do not recommend, and I do not recommend also using any oral zinc to those patients. Also, they looked at different oral antibiotics, theophylline, vitamin A, caroverin, alpha-lipoic acids. No solid data here, no recommendations given. If anything, the alpha-lipoic acid may be helpful, but we need more studies in the future. And the most prominent effect is from olfactory training. We have 2 studies, level 1. We have 2 other studies, level 2, 3 studies, level 3, and 3 studies, level 4. The benefit is clear to those patients. The harm is minimal, and the cost is minimal, because you can actually select any items from home to be able to do this. Given that this is an inexpensive option with minimal or no harm at all, the value of this option is very high, and it is highly recommended to be started to all those patients. Usually you can start doing this after 2 weeks if the sense of smell is not returned, and in one study it was combined with topical steroids, and the results were very positive. So if anything, I would recommend to give those patients topical steroids in addition to olfactory training. And of course, you are familiar with how we do this. We give patient 4 different smells. It doesn't have to be those smells, but in the original article where they describe this, they use rose, lemon, clove, and eucalyptus. And they make multiple sniffs for 10 to 20 seconds, prefer to have 20 seconds actually, twice daily. And in one study it showed that the patients who extended the use of the olfactory training for up to 56 weeks did better than those patients who did not extend the use of the olfactory training. So we recommend it as long as there's no problem with the patient and their sense is not returned. We recommend it up to a whole year. And to summarize the plans in terms of the management, first you need to assure your patient that recovery is in most of the cases. You need to be concerned about the safety issues around those patients. Olfactory training is associated with good outcome and is recommended, especially with topical steroids. However, systemic steroids is optional, and if to be given, should not be given in the first 2 weeks. Topical steroids alone is optional. Intranasal sodium citrate is optional. Oral zinc is against, recommendation is against use of oral zinc. And then we have no recommendations in terms of oral antibiotics, theophylline, vitamin A, and alpha-lipoic acid. Make sure again, if you're going to use systemic steroids, do not give it in the first 2 weeks. I also would like to make the same recommendation for the topical steroids. I would not use it in the first 2 weeks because that also increases the viral replication locally in the nose in the first 2 weeks. So if anything, any steroids can be given if the sense of smell is not returned within the first 2 weeks after the viral replication is decreased remarkably. With this, I would like to thank you and open the forum for any questions. Thank you.
Thank you so much, Dr. Mazen.